So I know the opioid, that's more so like pain. So you brought up the somatic and the psychological effects. So what about patients who are addicted to other things other than opioid? So
I don't know. It would be a useful research study to see, because it is.
only because you said something about somatic and the psychological effect.
Well, yeah,
on the body.
I've worked in some populations when I was in Chicago with addicts. Addicts are very tough. They're difficult. It's difficult to work with because
Right.
they're seeking something.
Yeah.
And I always wonder that it's a great question, because this does give you a really strong stimulus.
Mm-hmm.
So it'd be interesting to see if that's enough stimulus to reverse that drug seeking process.
Mm-hmm.
And most of that's behavior, right? They're seeking out,
Yeah.
it's you're not, getting somebody off of a big recreational habit of a drug of some sort, because they weren't prescribed that for a condition that they thought that they lobbied you to go get. The opioids, again, the people that...
Yeah, we're getting a little far out of scope, but it's difficult because there's a lot we do, we don't realize what we're doing. How much effect we're having on patients. A friend of mine just went through an EMDR seminar on eye movement. I forgot what the DR stands for. I forgot. But anyway, the base of
Direct
EMDR.
response, I think. Eye movement, direct response? Right? Yeah?
The D is something else. It's cross response.
Desensitization.
Desensitization response, yeah.
Yeah.
So the base of EMDR is to bring up your most vivid trauma at the time, and as you're recalling that vivid trauma, move your eyes saccadically, very, very quickly, side to side. You're like, I'm going, well, what the hell would that do? But then there's some really interesting theories behind it. Getting back to this part, when you're in a fear response, a really strong fear response, you're walking down an alley and somebody pops out of a thing, and you realize, oh my God, I'm about to get attacked, and it turns out it's nothing. It was just a cat crossing the thing. When you come out of that alley, you're a lot calmer than when you went into it. Because when you hit the fear response, it's a parasympathetic response that kicks back that drives you into relaxation. It's called Pavlov discovered it. The same guy did the dog study. He discovered it's called an orienting response. They think it's one of the mechanisms that how EMDR works. When you do saccadic eye movement, that's a fear movement in your eyes, and they think that kicks in a fear thing. And then when you come out of it, you actually hit into a calm state. So they're trying to take
Now they're using sound and vibration.
Yeah, they said for patients who can't visually track, they'll use tapping, saccadic tapping, side to side. Anyway, it's just another form of sensory input. The reason I bring that up is it's a sensory input that's changing a psychological approach. So your question on addiction, I think there's a lot it's right to look at, because this is it's such a strong sensory input. So today we're looking at MSK patterns, though. So whatever problems you came in with, you're probably going to leave with if they're in your no.
Dang it.
The other day you said this has a lot of the same effects as PEMF, like the electronic transport chain and...
No, that's laser.
Oh, okay.
That's laser. That's the transport chain.
Because you mentioned the healing times being massively reduced, and I know that's a part of the PEMF.
Actual tissue healing in laser is fairly quick because of that electron chain. But they're also finding with electrical stim, healing time decreases because of blood flow. So there's a profound effect on blood flow with electrical stim, controlling blood flow. So.
What system controls blood flow?
Cardiovascular.
Nervous. Thank you.
Autonomic.
Right? And we're affecting the nervous system. So we're actually affecting blood flow. Most of the time, when you use any, whether it's Rush or Stim, any AC curtain, DC or AC or even ultrasound, it's localized. Wherever you put pads, you're going to get an increase in blood flow because of, for a lack of a better term, squish, squish, you're moving a muscle. Okay, you're moving a little bit more blood flow because you're contracting the muscle. This, on the nervous system, we're actually affecting blood flow systemically.
So on this one, because him and I agreed over this a lot, how they're doing it. when you're in the full tetany mode, there's two waves and two signals in here. There's one that's going to throw you into tetany, or throw you in towards muscle contraction, which of course is going to increase blood flow because you're increasing oxygen demand. You're contracting a muscle, so it's going to increase blood flow to that area. There's a second wave behind that that's subsensory, actually, and what they're finding is these little subsensory waves can cause a. Look up the article again, but they came out of Korea, and I think it was telling some students where they did subsensory stimulus to the sympathetic chains in the thoracic spine, and it causes increased blood flow in the foot because it just opens up, sends more blood down to the foot. So it's a kind of a way to increase blood flow without causing vasodilation.
Correct.
Because it increased some of the blood flow velocity to the foot. Because sympathetics would technically constrict peripherally, but you can also increase velocity, which can actually increase blood flow to the foot. So it's counterintuitive to how you would think about it. That's why it took me a minute to figure out, well, wait a minute. I'm stimulating sympathetics to decrease blood flow, but it increases blood flow velocity. So a nice trick is to do the contractile piece where we're getting a lot of blood flow to the area, then hit the sympathetic side where now we're going to go back down to vasoconstriction, but increase the blood flow velocity and clear it. Cool.
Cool.
So yeah, this is just this is kind of the heart of the machine. You'll see it today. They're really easy to use. Touch screen, it's self-explanatory. Turn it on, plug it in, put the time up, and then we'll go over the parameters here. But the parameters pretty much stay the same for what we're doing today. We're not really changing those much. There's some other stuff down the line. We're playing with different pulse sequences more for training and rehab. Yeah, the only trick is once you start this, to turn this up, this is the volume, you have to press it every time you do it. You'll see why, because you don't want to accidentally turn this up. And then the PRS, which is kind of the kissing cousin to it. Same thing, same concept, turn it on, turn it up.
Is that something that you can sell to your patient to take home, or is that something you can offer?
They sell them. I know they do sell them. We just had a couple interesting athletes order these.
Yeah, we have.
A lot of professional teams are using these. A lot of athletes travel with these things because it's therapy on the go. I think there's two ways they can buy them, and then there's a rental program too.
Correct.
And he was telling me about one of the practices had a pretty large rental program going where they were renting, what was it, like $300 a month for these?
About that, yeah.
And the guy had 10 or 12 of them out for rent. So, pretty good passive income. I don't know the cost offhand to buy, but it's not cheap.
What about the RX? What was that one?
So RX is $12,000. It's about a quarter the price of what it used to be. Before we kind of took over, I brought that in, and before we got into manufacturing and all that kind of stuff, it was close to 30. When I bought it, it was 30,000. I had to pay for every minute I used on the machine, and I was up to like 5,000-6,000 hours in minutes a month because it was using it that much. So when we jumped in, we started, the ARPneuro side, put more science behind it. We got in control of manufacturing, lowering it down to a point where it's relatively affordable than what it was prior.
What are these? These are around.
Those are 3,000.
Yeah.
There's all financing things. We get into all that kind of stuff on the back end. More about understanding the science is probably necessary, but I can answer all questions and about that.
It looks like they're portable. How long does the charge last?
6 to 8 hours.
6 to 8 hours on max power.
Okay.
So if it's less than max power, then it'll last even longer than that.
Do you have to let it charge up before you use it, or can you plug it in and use it?
That is battery powered as well, but you can plug that into a wall too.
You can use it while it's charging. The RX.
Yep.
This one you can't.
Okay.
This one has to be charged. You can't plug it in and use it.
Yeah.
But that one you can if you ran out. I think that happened to us. We were playing with it and we ran out.
Yeah, I just realized, I think when I worked at NC State, what's it called? They had like a dozen of these, and they just like put them on, like they'd just come in.
How long ago were you there?
I was there in 15 or 16.
Okay, okay, perfect,
16, 17.
Yeah.
Yeah, with Elise,
okay.
little blonde, short girl.
Okay.
Yeah,
Excellent.
Bradley Chubb was there, and he might be done with his football career. So.
We're already in works that I'm probably gonna start to treat him.
Oh wow, that's awesome.
Yeah.
Yeah, you'd be shocked at how extensively this is in major league sports, all the sports.
Yeah.
They're calling me. Most of the time, they're calling him because he's the one that actually does the training, virtually. But it's amazing. It's not. It's different than giving somebody a good adjustment, a good massage, a good physical therapy session, or whatever. You might come home, you tell your wife, you go through this, you stop people on the street and be like, I see limp. You have to see these guys. It's different. And once you feel it, you'll understand. And once you see that, wow, somebody's got an ankle problem, and I treated the VMO and the IT band, and their ankle completely went away, they look at you with three heads. They're like, I've been dealing with this for 10 years.
And how long would it take for that to actually happen? How many treatments would you say?
One,
Yeah,
Just
you
one.
see big improvement.
you'll
with one
see the
treatment.
difference.
Yeah.
I'll give you an example, right? So I had a dad that really, he was very heavily involved in pro baseball. So he understood. He knew, he's heard about this before. His oldest daughter is collegiate bound, 6'3", star volleyball athlete. She did not play her entire junior year, right? She's looked at by Wisconsin, Michigan, Michigan State, right, for full rides. She didn't play junior year. Senior year, she doesn't play at all. Or, I'm sorry, she doesn't practice at all. She never finishes a game. Dad came to me 8 days before she has to go to nationals in Minnesota. I treated her 6 times in 8 days. She played 11 straight games and got offered 5 scholarships. He came back and he was like, you just saved me $45,000 a year times 4 years. I don't care. I want one of them. How much is it? I want to buy it. And every other kid that I have, because these kids are crazy good, they're just big people. And, one was at Rutgers, one's at Texas Tech, treat them as well. I mean, it's
The fascinating
30
with-
patients
The
from
fascinating
it.
with the young athletes, it responds like that
Yeah.
because they're so adaptable. And I think what's good about this will get you to the door. Go talk to an ATC about adjusting their pay, and half of them will be like, I don't want you touching them. And no matter what you do, if you want to be a sports chiropractor and pay university level or professional level, you're not getting anywhere without the ACC's approval. So.
With our
Jake and I have been in I don't know, how many you say, 50?
Yeah, probably.
50
Maybe more.
training rooms?
Yeah.
Where you come in and, they're very, very, very territorial.
And
You come in and you're like, we got
The fascinating
something.
thing, I was talking to Brian the other week, and I just mentioned who it was, the Cubs ATC called him and said, come down here. And he was at Wrigley doing his thing. So once they realize what it is, or they've seen it, they want exposure to it, get you in the door. Unfortunately, it was the Cubs.
Better if it was the Bills, but that's okay.
I think they purposely held it back from Aaron Rodgers.
Oh, I said I'll treat him at the end of the year. As soon as the Super Bowl's over, day after the Super Bowl.
It was an interesting story. They were monitoring his place, and I think he lives in North Jersey, the day after his injury, and the first thing that was delivered was a big hyperbaric chamber. So, kind of interesting. But anyway, the other part of this that I really like, most stim units, put the pads on, go lay down. This one, put the pads on, here's the exercise I want you to do. So we're going to actively move you through this, and I think that's actually what's setting the repatterning so quickly. It's not a passive thing we're waiting for you to do with the body to pick up. We're going to put you through the pattern. Like today we're going to talk about anterior posterior sling therapies. Those are the two main ones we're focusing on. And giving you anterior posterior sling exercises while you're doing it. So that's, we'll talk a little bit more about. I think that part of the discovery of this anterior posterior sling patterns and treating those was kind of the game changer for this thing, because it's really one of those patterns we can treat that affects the entire chain. So probably, and that's what I was talking to Brian about when he first started doing all this scanning. I said, figure out how many times you put the pads in these areas. He's like, well, I kind of put them there all the time. I'm like,
You didn't necessarily explain the scan though, right? Like how that kind of works, right? So what I was doing kind of in the beginning is, at least the way I was taught, you know, obviously somebody had to show me how to use that machine for the first time. You take one of the, you know, black clamshell pads with the sponges, the old as opposed to the sticky electrodes, and you can actually move that on the body. And when it goes through normal tissue, it's very tolerable. When it hits something it doesn't like, or there's some sort of resistance, is that an appropriate word to use? Then
some kind of tissue damage.
there's tissue damage. It, lack of a better term, it lights you up like a Christmas tree. And you're like, yeah, but you have a knee problem, but you scan around the knee and there's nothing there. And all of a sudden I get up and it's either, you know, mid-groin, it's an IT band, it's a QL, and you treat here and here, and somebody's had knee pain for a long time, and you're a foot away from their knee, and they walk and can jump and walk. They're like, I can't get this treatment anywhere else. Everybody's been treating here. You treated here, and this went away in 20 minutes. I'm coming back. How long do I have to?
But
It's
when,
not- it's
when you started
easy-
describing
easy
that,
therapy cell.
right? When you
know.
started describing that, but the problem is the scan it hurts. It's at a high intensity and it hurts and it takes a long time. And so, what if we could figure out points that will probably hit about 80 to 85% of your patients? We'll take care of it, and then you know we could work out from there. And if it doesn't work, then we can jump back to a scan. Turns out when we do these points, most of the time they never do the scan because they don't need it because it's working. It's really effective. So now we get to Dr. Brian's favorite subject.
Oh boy.
Your favorite. Now we get to
Double
sign.
record this?
I always had the problem with why are muscles dysfunctional? Why do they get stuck in these patterns? You know, and the original work came out of Yonda and Levitt, the upper lower cross patterns. You know, our flexor sides tend to get hypertonic. Our extensor sides tend to get hypotonic, right? So flexors, pec minor, bicep, they tend to shorten as they get irritated, okay? And then what happens is, I'm not sure the other ones, the extensors lengthen because of how they're built. They probably lengthen because if I shorten this, it inhibits its antagonist, right? So if I shorten the pec major, the rhomboids, middle trap are going to get inhibited because it's picking up, this is contracted. So through reciprocal inhibition, it's going to start to shut down its antagonist, right? But another hypertonic muscle, bicep. You ever find a hypertonic tricep? Almost never. I was thinking of my 4th grade teacher as she was writing and her arm was like going like this underneath. Still remember that. What? I don't know why. Mrs. Maddox was, I still remember her name. We all saw, I mean, every one of us was, why is her arm shaking? But you know what? It helped me all these years remember that triceps are hypotonic. So there. Could be mean, but it worked. Did you ever find a loose adductor? Almost never. Did you ever find a real tight glute med? Almost never. Because they're so. What I'm trying to get to is muscles come into certain patterns. As I'm practicing over the years, I'm going. It's always the pec, it's always the bicep, it's always the adductor, it's always the psoas. We go through our muscles du jour over the years. Psoas was a big one for a while, right? Psoas always tight, and this, you know, you rarely see like a older patient coming in going, boy, my back really hurts. Boy, my back really hurts. And we fall into flexion a lot. We become flexion dominant over time. So it's that flexor side that really gets it. No, and what controls some of our muscle side is muscle spindles, right? So muscle spindles are embedded inside the muscle, and they're the intrafusal fibers. Extrafusal fibers, sorry, intrafusal. So they're embedded inside the muscle, and they're hooked into alpha motor neurons, right? So what do muscle spindles respond to? Stretch. Right, so as the muscle lengthens, the muscle spindle tends to fire. And when it fires, it causes the muscle to shorten. Think of a knee-jerk reflex, right? That's the alpha, that's the muscle spindle firing. The trick we forget about, though, is as that muscle shortens, if the spindle doesn't shorten, we're going to lose this. And spindles respond to stretch, right? So if the spindle begins to shorten, the muscle begins to shorten and the spindle doesn't, what happens? Muscle shuts off. Because now the spindle's slack. But what innervates the spindle? Gamma motor. So that's the alpha gamma piece. So you have alpha that innervates the motor part of this. You have gamma innervating the spindle. Okay? So those two have to work together. As the muscle shortens, the spindle has to shorten. Two separate systems shortening this, though. These guys, they're still trying to figure out alpha gamma loop. But there could be a disconnect sometimes, too. If that alpha gamma is not working correctly, you can get muscles that aren't going through complete contractions, aren't firing correctly. And this is kind of a key concept because it comes into play. This is sensory side, too. There's some sensory input here. Has anyone heard of arthrogenic inhibition? So if I have damage to a joint, like arthritis, that's why they call it arthrogenic. If I have damage to a joint, like my knee joint, your quadricep becomes significantly weaker. Now the theory that we were all taught was why? Because you're not using your knee as much because you're bone on bone, which actually is false. So damage to a joint actually causes neurological inhibition of the muscles that connect to it. Okay. So there's a neuroinhibition, which now there's a vicious cycle setting up. I injured my knee, right? I injured my knee. Now I have inhibition of the quadricep. Now I'm trying to get my knee stronger, but I can't because it's injured because I get this arthrogenic inhibition. And now my knee gets worse because my quadricep's weaker. And I can't get the right loading on it. I can't get the right shock absorption. So you set this cycle up, like an ACL injury. You get arthrogenic inhibition, and it just keeps going around and around until it keeps getting worse. Okay. So where does this, not to get too far into the science, but where does this come from? Well, there's a sensory neuron that hits the spindle fiber that comes from the joint. And it's I think it's an alpha fiber, I think. I can't remember. I'll show you what up. They don't say it here. There's a sensory fiber that comes from the joint that innervates the spindle. And when you get injured, it actually shuts off that sensory fiber. When it does that, it screws up the alpha motor, that alpha gamma loop. So now you get aberrant firing of the muscle, and you start to get weakness. So they have to calling the muscles inhibited, and it actually sets up an inhibitory signal actually comes down from the cord. So this is, you could work this quadricep out all you want. It's inhibited at the neurological level. It's not going to get stronger. So it's an important concept to understand that when you injure a joint, you got to kind of reset that muscle. So one of the things I found fascinating with the ARPneuro is there's so much stimulus coming in, it seems to reconnect that, wake up that sensory stimulus back from the joint to get this working correctly. So, because when Brian started talking about these athletes had these injuries for years and all of a sudden they're feeling better, and I'm like going, well, how are they feeling stronger that fast? They can't beat like 2 days where they're feeling stronger. So it takes...
And we're not treating where they pointed to their injury either.
Right.
Of any sort.
Right. But it's
Just wait.
Yeah.
Yeah.
So this inhibition can kind of spread throughout. So this neurological inhibition of muscle, and what it got me thinking about that is, for the first couple of weeks you work out or start a new workout regime, you get stronger. But all those gains are neurological. They're not physiological. It takes 4 to 6 weeks to actually cause changes inside the muscle itself. Everything else is neuro. Which is how gyms make money, because they get you in there for 2 weeks and then you kind of fade away and then come back a month later and work out again and kind of, you never actually ever get stronger because you're not going more than 6 weeks in a row. So. But this arthrogenic inhibition, I think, is one of the keys that we're overcoming with the ARPneuro to help get them stronger fast and reset that.